guys, welcome back, part 2 for the Trauma Chapter 1. And let's talk about what your role as the paramedic is in trauma. Oh boy, here we go, okay? If I can't impress anything upon you guys, this is it right here, all right? Appropriate patient assessment, triage of the patients, getting them to the right place, expeditious patient care, and transport to the appropriate medical facility. That is your job. It's kind of simple, all right? Or at least you would think that it's simple, but yet we complicate it so well, okay? I can't stress this enough. Trauma patients, we need to get them to a trauma surgeon. No amount of IVs, no amount of airway, no amount of ventilation, no amount of giving drugs is going to substitute a highly skilled trauma surgeon from taking care of that patient, okay? The best thing you could truly do is get them going to the hospital. And on the way, then we're going to pull out that paramedic hero stuff. Not until then, okay? Get them to the trauma surgeon. I can't stress that enough. Can't stress it enough. Now, here's the problem. Is sometimes our patients put themselves in a position where they can't get out of it. And so, again, this is things that are going to slow us down, and that we need to, again, we need to be able to get them out. But again, we start delivering care while we're inside. But the delivery of care should not be slowing us down from getting them to the hospital, okay? Again, I cannot stress that point enough. Cannot. All right? So get your general patient assessment. Again, increases your likelihood for some scene hazards. Look and see what happened. Analyze what happened in that incident. Make sure that you're safe in which to do so, by the way. Look at the impact of the environment on the patients, the assessment, and the care. Establish oversight of the scene. Remember, they're going to be looking to you for leadership, and hopefully you've got somebody else there that can manage the scene while you manage the patient. Every now and then, you're going to be the guy or the girl, okay? So be aware of that. Apply trauma triage guidelines, and then determine the appropriate destination. That is your job, okay? So the scene survey, make sure it's safe, all right? Factors that may hinder or help us. What caused the incident, the mechanism of injury, okay? The kinematics of how this happened. You need to determine those things. The environmental impact considerations, again, if they've got things leaking, oh yeah, the car's in the river, we got to remember them. Do I need to evoke a rescue before I decide to worry about this patient's injuries? And again, the scene oversight. Remember, if they're doing something crazy and not safe, we need to stop it, okay? And sometimes we have a different vantage point than the people that are hot and heavy, let's say in an extrication. So these are things, or if they're doing something that's actually hurting the patient, where you're going to have to say, whoa, stop. Well, all right. So remember, don't be afraid to do that, all right? Scene safety, again, is paramount for you, your crew, the patients, bystanders, okay? So, again, mitigate these things. You have to mitigate them, all right? And if the scene is not safe, you probably shouldn't be getting in there, and you should be preventing people from going in there as well. You got a gigantic hydrofluoric acid leak. Maybe this is not, being close to the green cloud is probably a bad idea. Okay, so determine the mechanism of injury, and again, the strength and direction of forces involved. Did those forces change? In a traffic crash, you might be kind of playing a little bit of a detective as to, okay, they hit, they bounced over, they rolled over, and they came out, and they flew out of the car, okay? So all of these things have an impact on how the person got injured and where they might be injured where we can't see it, okay? So again, information about the mechanism of injury is kind of a nice clue to tell us where this person might be hurt, okay? So index of suspicion is a mental summation of where you think the injuries are due to this, okay? And examine your trauma patient, the primary and secondary exam, okay? And if you know for a fact that the steering wheel is caved in, when you get to the chest, you should be looking for signs and symptoms of those injuries. Okay? So knowing that, again, helps us to determine the injuries that this patient actually has. Okay? Vital signs, Glasgow. I kind of prefer APU to start, but Glasgow is very helpful. Your level of consciousness, and again, your signs and symptoms of serious trauma, traumatic brain injury are the greatest threats to mortality. Okay? So, and then rapid transport. Oh, I can't stress this enough. Get them going to the hospital. Don't sit there and do things on scene. Get them going, especially if they're a critical patient. Yes, I've been talking about if they're in VTAC, VFib, you should fix it right there at the scene. I'm talking about a medical patient. This is trauma. Trauma. Nope, let's ride. Okay? We need to get going. Please understand the difference between the two. Okay? Please understand the difference between the two. Again, a traumatic mechanism, we don't have the means or the ability to fix them. The best means and ability that we have is rapid transport. Okay? And then number two, everything else that we do is that paramedic stuff. All right. So remember that, again, you might be the person who is actually the highest ranking, highest trained person there, especially in your more rural areas, okay? Make sure that you establish a scene oversight. And then if you have an incident command system in place, again, you need to report to the incident commander and begin your assignment. They're going to tell you what to do. Hey, you take care of patient 1. Hey, you take care of patient 2. Sometimes you might be the guy, hey, I get to take care of all the patients. Yay, okay? So your primary assessment, you form your patient, make sure that you see spine precautions. Again, this is stuff, guys, we have been doing for a very long time, okay? Now, the cups is determining how sick that they are. And by the time we take the good look at them, kind of like a pediatric assessment triangle, yeah, this is where we go, yeah, they're critical, they're unstable, they're potentially unstable, or, yeah, this guy's going to be okay. Okay, so it's another little mnemonic to, is this patient critical? Again, and understand that critical means they're about to die. The unstable means, yeah, they're serious, potentially unstable. They're doing good now, but because of something that's happened or an injury that we see or maybe feel, this guy has the potential to go down, okay? And then these are the guys that, yeah, they'll be fine, okay? So again, it's not that we don't continue to monitor these folks. Your stable patients, we usually do a focused trauma exam, go to the part that's owie, okay? If they're unstable patients or they're potentially unstable, check everything. I'm going to star that one up here, though. Just because if they're potentially unstable or critical, we still should do our rapid trauma survey. For our stables, truth be known, we usually check out the area that's hurting first, but then I'd highly recommend going back and doing this because there's a good chance we're going to find something that's wrong. Trend and watch your vital signs. Again, if it's a stable patient, it's usually every 15. Unstable or worse is every 5 minutes. So let's take a look at the assessment video here, shall we?
The most valuable tool an EMT can possess is excellent patient assessment skills. While there are differences between how we assess medical and trauma patients, the initial approach is largely the same. Take standard precautions for body substance isolation based on what you know of the call. Gloves and goggles are a minimum for every call, but you may need a gown for massive bleeding or face mask if airway management is going to be required. The scene size-up actually begins with your dispatch information. What you are told about the location of the call and complaint can give you information about what to expect when you arrive. For example, if you are responding to a martial arts studio, you might expect a fall or musculoskeletal injury. Upon arrival, ensure the situation is safe to enter, meaning that there are no hazards to the safety of you or your crew, such as a loose dog, poor lighting, or a fight in progress. Determine the number of patients who will need your attention and whether or not additional resources, such as ALS responders, law enforcement, hazmat, or the power company will be required. Call for help now if additional resources are needed. Once the scene is secure and additional help has been called if needed, determine the mechanism of injury based on the patient's chief complaint and initial presentation. Or, if the patient is unconscious, bystanders, or scene clues such as an overturned ladder or vehicle deformity may give you important information. If the patient has been involved in any type of fall or blunt force trauma, or presents to you on the ground without explanation, begin manual immobilization of the spine now until you are able to confirm that a spinal injury is unlikely.
Guys, in one other little sidebar to that, the spinal precautions, stabs in the chest wound, by the way, unless it's directly affecting the spine or you think that the knife actually hit the spine, actually they're saying don't backboard those guys. Okay, so kind of keep that in mind.
Your primary assessment should be done the same way every time on every patient. The purpose of the primary is to find and correct life threats such as apnea or hemorrhage. Having a consistent approach to the primary assessment will ensure that you identify the most pressing, life-threatening issues with your patients every time. The primary assessment begins when you determine your general impression of the patient. This is often stated as a level of distress, such as mild, moderate, or severe, sick or not sick, or as an obvious injury, such as head trauma or a suspected leg fracture when deformity is readily apparent. Next, determine the patient's level of consciousness. Discover whether they are alert when you come in, meaning they are aware of your presence. If they do not seem aware that you have arrived and are presenting with their eyes closed, attempt to gain their attention by using loud verbal stimuli and, if unsuccessful, appropriate painful stimuli such as interdigital pressure. If they do not open their eyes or speak to the verbal or painful stimuli, they are said to be unresponsive. Regardless of level of responsiveness, introduce yourself and attempt to gain consent to treat the patient. Of course, you may treat an unconscious patient using implied consent. If the patient is alert, ask them for their chief complaint or the main reason you were called. In the event of an unresponsive patient, you may be able to determine the problem from bystanders or the scene itself. Your assessment of the airway is next. You will need to confirm that the airway is patent, and if not, open it now using a jaw thrust technique to avoid compromise of the cervical spine. Look inside the airway to make sure that there are no obstructions or substances that need to be suctioned. If suctioning is required, clear the airway now. In a situation where it appears that the patient is unable to maintain a patent airway, such as in a patient with an altered level of consciousness, insert an OPA or NPA now.
Wow.
Assessment of breathing comes next, including respiratory rate, rhythm, and quality. You will also need to determine if the patient has adequate tidal volume. To begin this assessment, you should bare the chest to check for any wounds or bleeding. If an open chest wound is apparent, an occlusive dressing should be applied. Also look for medical alert tags. It is not uncommon that a medical emergency precedes a traumatic event. A bare chest will also help you to listen to lung sounds without interference from clothing. In addition to auscultation and inspection of the chest, you will need to palpate the chest wall for stability and to ensure that the patient doesn't have subcutaneous emphysema, crepitus, or pain on palpation. Oxygen should be applied now if it is indicated. For respiratory rates less than 10 or greater than 28 to 30, or for inadequate tidal volume, ventilation should be assisted using the bag valve mask attached to 100% oxygen. The radial or carotid pulse can be used to assess circulation of a trauma patient. If a radial pulse is not present due to poor perfusion, move to the carotid pulse. Check for pulse rate, rhythm, and quality. Assess the skin for color, temperature, and moisture. Another way to assess for distal perfusion is by checking capillary refill time by putting pressure on the nail bed and counting the number of seconds for blood to return to the area after it is blanched. Normal capillary refill time is less than 2 seconds, indicating adequate distal perfusion to the extremities. Control any major bleeding if present and possible. You can begin to control external hemorrhage with direct pressure. In some situations, a patient will present with internal bleeding. Internal bleeding from, say, a liver laceration or damaged kidney obviously cannot be controlled by EMTs. Therefore, you will need to begin treatment for shock, which includes lying the patient flat and covering him or her with a blanket to preserve body heat. While you already determined level of responsiveness using the AVPU scale, It is now time to determine level of orientation using the patient's answers to questions about their name, time of day, current location, and events leading up to the EMTs being called. This is called alert and oriented times 1, 2, 3, or 4, depending on how many questions about person, place, time, and event they answered correctly. You could also use a Glasgow Coma score to report level of consciousness in trauma patients. Now is the time to assess pupil size and reactivity to light as another measure of neurological activity or disability. In some situations, a patient will present with major trauma. Major trauma patients need to be fully exposed, with their clothes cut off or otherwise removed.
A happy trauma patient is a naked trauma patient. And that includes their socks, their shoes, everything off, okay? Everything. They are naked, okay? That is where you need to have them. It's going to help you in the long run, all right? Trust me.
An isolated injury, such as an ankle fracture, could have just the area involved exposed. Based on the information gathered in the primary assessment, identify and treat any life-threatening conditions. Any insult to airway, breathing, or circulation, or neurological disability, including altered mental status, indicates a critical patient. If the patient does have life-threatening conditions, begin packaging and transport now. In a situation where no life-threatening conditions exist, you will likely stay on scene for a while to gather more information, take vital signs, splint injuries, and treat for pain. While vital signs are actually the first part of the secondary survey, it is unlikely that you will take these yourself as you will be busy talking to the patient. It is appropriate to delegate vital signs to a partner so that the information can be gathered simultaneously during your history taking. Note that in the critical trauma patient, the history, secondary assessment, and reassessment are all performed en route to the trauma center. First, gather a history of present illness by asking the patient what happened today to make them call EMS. The mnemonic OPQRST can help explore a complaint of pain. O stands for onset. You would ask what the patient was doing when the pain started or what caused it. P stands for provocation and palliation, meaning what makes it feel better or worse. Q stands for the quality of pain. To assess quality, you will ask the patient to describe what the pain feels like. They should give you an answer such as sharp, back, and whether it be herbal or over-the-counter preparations to the pressure.
You guys are good with that part of it.
For example, if you are treating a simple musculoskeletal injury, it may only be necessary to examine the injured extremity. In an alternate situation, where the patient is unconscious and cannot relate to you the chief complaint or mechanism of injury, then it is appropriate to do a head-to-toe assessment which begins naturally with the head. Use the tools of inspection, palpation, and auscultation to find any abnormalities that might be contributing to the patient's condition.
All right, so speaking of things that are bothering me on this right now, the big thing that's bothering me right now is this dude still has his clothes on, okay? If he's unconscious, that would consider him a critical patient. A stable, even a potentially unstable or critical patient, newsflash gang, yeah, take those clothes off.
When assessing the head, check for skull fractures, bleeding, stability of the orbits, blood or fluid in the nose or ears, or loose teeth. Check the neck, both front and back, for tenderness when the spinal vertebrae are palpated, heat or warmth which could indicate a fracture, jugular vein distension, or tracheal deviation. Although you have already examined the chest once, it is not inappropriate to go back and reassess the chest now for paradoxical movement, stability, or signs of increased work of breathing. Check all 4 quadrants of the abdomen for tenderness, rigidity, masses, bruising, or bleeding. Push anterior to posterior and laterally on the pelvic wings to test for stability, pain, or crepitus. Do not rock the pelvis. Check all 4 extremities for wounds, stability, and distal circulation, sensation, and movement, often referred to as PMS. Don't forget to check the posterior of the body for bleeding or other injuries.
All right, you guys, speaking of the back, by the way, make darn sure that you roll the patient over and take a look at their back.
You think is likely the problem, called your field impression, and inform the patient and your team of the treatment plan. As soon as time permits, usually every 5 minutes for unstable patients and every 15 minutes for stable patients, reassess your patient.
All right, yeah, I'm not going to go too much into that because, again, you guys have done a lot of this already. I don't want to go too far into it. It's a good review for you. So, again, the golden hour is from when the incident happens till they're in surgery. I'm going to stress that again. From when it happens to in surgery, okay? That is your golden hour. So basically, your time in that should not be that long, okay? And so we really need to think about how we're going to get this person to that surgeon within that 1 hour time period where they're on the table, they're working on, okay? Your scene time usually for a trauma is that's packaging, primary, secondary, and emergency stabilization usually should be less than 10 minutes, okay? So that's where we get that 10-minute off-scene time. Air transport. My boys at Shands Care are going to get really mad at me. But I want you to really stop and think about this, okay? Really stop and think. How long is it going to take for them to fly to you? How long is it going to take for the transfer of a patient? By the way, 10 minutes is usually a good one. If they have to secure the airway before they get them in the aircraft, you're looking at 15 to 20. Okay? Gang, if you are, and this is kind of my rule, if you're within 30 minutes by driving to a trauma center, it is better to drive them. Okay? Unless there is something that's going to delay you on scene, like they're entrapped. Again, that's where you could fly the helicopter in, and you've got that time in which to do so. And guys, I've done this before. I've left a scene where Floor Home Granted, Shands Care was landing as we left the scene. Okay, literally, I got to Shands 1 minute behind them. And they were the guys with the helicopter, okay? So you got to remember there's all that little time versus taking them straight in to a trauma center, okay? So don't forget those little things. Again, if I'm out in Cedar Key or if I'm way out in Crescent City, yeah, 100% aircraft is the way to go, okay? And again, don't also think about can you meet the helicopter, okay? So that's another option. Can you meet the helicopter somewhere? Okay, that's going to be a little bit closer in a probably more safe area. You meet them where you're not deploying your resources as much. So again, it was very common for me when I was in Crescent City to drive to Satsuma to meet the helicopter. I had a fire crew in Satsuma. I had the fire crew with me from Crescent City, so we weren't depleting the zones of resources. Okay, so this is the way that you can do that. All right, now. Aircraft, by the way, it can reduce time in certain situations. I don't want to discount the use of air medical. But one thing you're going to learn very quickly is that it takes time for the aircraft to spool up, okay? And I say this from being at Shands Care. From the time they got alerted till the time that they were taken off, they love to tell you 7 minutes. I will tell you probably more around the 8 to 9 minute mark is where they were at. And that's everything going perfect. The aircraft was sitting out in the bed. It was sitting out on the pad. Again, if they're having to pull it out of the hangar, again, they got to do all their pre-flight checks. So again, if you think that you need an aircraft, again, alert them early, because if all they have to do, if you're putting them on standby, all they got to do is flip a switch and start turning the rotors. Okay, so they can get all that pre-flight done. All right. If you get there, you see that you didn't need them. Guess what? You stand them down, okay? And I will tell you, by the way, most of the aircraft companies today, if you call for standby, 3/4 of the time, they're probably going to spool up and go ahead and start towards you, okay? It's just part of their doing business, all right? Now, so again, determine which ones are you going to, the decision to transport. So again, all of these things, this is your the transport criteria, okay? So again, think about the mechanism of injury. Guys, just because they don't fit trauma alert criteria, does that mean that you can't go, the significant mechanism of injury? And the example that I use is a little kid that got hit by, he was doing a piñata. They were taking swings with a metal bat at this piñata. The little 3-year-old kid walked out. The little blindfolded kid didn't know that his buddy was there. He plunked this kid. Now, when I get there, the kid's talking to me, a little bit dazed, not too bad. Pupillary response is good. Vital signs all within normal limits. And then they showed me the video. Trauma alerted him. Took him to Halifax. The doctor is just absolutely getting on me once we get there. I said, stop. Doc, take a look at this. Hey, sister, come show that video. Sister was with me. And I said, hey, watch this. Put the camera up there. Guess what? Watch the camera. The second thing, he was like, get this kid a CAT scan immediately. Yeah, immediately. Imagine that. The paramedic wasn't stupid. So my point is if you've got a significant mechanism of injury that you think has caused an injury, call it. Folks, they allow for a 25% over triage rate. The over triage rate is acceptable, okay? Now, again, we don't want to alert everybody unnecessarily, but they expect 1 out of 4 to be over triaged, all right? Now, what is not acceptable? Under triaging somebody. Absolutely 1,000% unacceptable, okay? When in doubt, take them to the trauma center. When in doubt, go ahead and call the trauma alert, okay? Worst case scenario, they cancel everybody and you get a mad surgeon for a couple hours, okay? It's okay. As a matter of fact, most of the trauma surgeons nowadays really don't lose their mind when you do that, okay? Now, if it's a continuous problem with you, they might be pulling you aside and say, hey, it's time to start making some better decisions, all right? So again, now injury prevention, do we have an obligation to do this? Absolutely. And this falls back to an ounce of prevention is worth a pound of cure. So when you get the chance to be involved in these things, use your knowledge and your experience as well as your knowledge of trauma to express these. The biggest ones I can think of is your car seat programs, using seat belts, the cutting up the car at the local high school, all of these things. And by the way, you can make some of those look really convincing. This is it's called Shattered Dreams. Is one that they did in Austin County, Texas. But I will tell you that we've done them in Florida just like this. And we've made it pretty gruesome, by the way. So again, make sure that you fill out your items for trauma registry. The good news is your electronic report already does this, but fill in those things because that's how we get money for doing that, as well as it allows us to categorize these traumas so that we can better work on fixing problems, okay? And last but not least, trauma has a QA system in place where you might be actually asked to be involved in it. And I highly recommend this, okay? And I can tell you, it's not a butt-chewing session. It is a session where you can actually, and true QI, by the way, is not punitive. We don't look for the individual providers. We try to find faults in what happened and better ways to fix them, okay? And that's what true QI does. By the way, anybody that uses QI as a punitive tool, you want to hear me go off on a rant, you will hear me go off on a major rant. And a lot of the chiefs and senior ones that do it, I lose my head about it, okay? Quality assurance and quality improvement is to make sure you get better. A paramedic doesn't come to work and say, you know what, I want to treat somebody bad today. It just doesn't happen. So guys, if you get a chance to be involved in that, by all means, please do so. All right, that is the end of this. And I know I went a little long with the video. I apologize. But again, I think it's really important to understand that. All right, we'll see you guys on the next one.